All right. Good morning, everyone. Welcome to Community Cares and Project Echo, the survivorship series. Today, we have such an interesting and amazing session on shame, stigma, and the female cancer care journey. So, thank you for joining today's session. This is just some general housekeeping rules. Keep your microphones muted during the presentation unless you're asked otherwise, or at the end, we'll be doing questions and answers, and you can unmute during then. If you have any questions throughout the presentation, please put them in the chat box. And we are recording today's session. A quick disclaimer that the information contained in this presentation is not a substitute for medical consultation, and the physician should always be consulted for any health problem or medical condition. So today's agenda, we're going to do a Project Echo series overview, introductions, the presentation, a case study, and then we're going to do questions and answers at the end. A little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. For more information on Project Echo, you could go to echo.unm.edu. And today, our presenters are also from New Mexico. So here are our presenters. I'm going to introduce them. Monique Montes de Oca is a bilingual licensed clinical social worker with over 15 years of experience in the field of social work. She serves as a senior patient support therapist at the University of New Mexico Comprehensive Cancer Center, where she provides individual, family, and group psychotherapy to patients and caregivers navigating the cancer journey. Monique is a passionate healthcare professional that integrates holistic and evidence-based healing modalities into clinical practice. Her professional interests include psychosocial oncology, health equity, cancer survivorship, integrative oncology, and sound healing. She is committed to improving access to culturally responsive mental health care and advancing innovative approaches that support the emotional well-being of individuals affected by cancer. Myra is a first-generation Hispanic woman with roots in Machi, Chihuahua, Mexico, where her parents immigrated from. She earned her Master's of Social Work degree with a clinical concentration in 2020 and has since built a career committed to advancing community health and well-being. She also brings 13 years of experience across diverse academic settings and roles. Myra's experience extends to research, where she has contributed to projects addressing reentry, unintended pregnancies, opioid education, inequities affecting women, academic detailing, and case management. She has also been active in the Motivational Interviewing Network of Trainers, MINT, facilitating motivational interviewing workshops with a special focus on Spanish-speaking and Latinx communities. Currently, Myra practices as a therapist, providing direct support to patients. She integrates approaches including cognitive behavioral therapy, dialectal behavioral therapy, eye movement and desensitization, and reprocessing, along with other therapeutic modalities to guide individuals in their healing journeys. Her clinical work reflects her passion for empowering youth, families, and individuals through compassionate, culturally informed, trauma-focused care. We are so lucky to have them here, especially since in New Mexico right now it's 8 a.m. So thank you both for being here. We really appreciate it. And I'm going to pass it to you, Monique. Thank you.
Thank you, Sarah. Thank you, everyone. I do have my tea here. Cheers to everybody. I know most of you are on East Coast time. We're happy to be here. And we're going to talk about motivational interviewing and how it can help in dealing with female cancer patients, especially with shame, stigma, and any other barriers that arise. Next slide, please. Ooh, do you want to take this over, Sarah? I wasn't prepared on the pretest. Okay.
Yeah, so I just launched it. So on everybody's screen, it should show up. So just answer true or false, and then we'll do the post test at the end. And then I have a slide with all the answers. So we'll give everybody a minute.
Yes. Just a few seconds to fill this out. Some,
Should we just wait it's 30% of people. So if
yeah.
you guys want to fill out.
Whenever you see most people, we can move forward. So,
All right, just a few more people want to do it, and then we can move on. All right, I'm going to end the poll and then we can move forward.
awesome. Thank you. No conflicts of interest to report. We aren't paid by Big Pharma, so that's probably one of the biggest things we're excited to say here. Today is about education and use it as however it shows up for you in your own clinical um, judgment. Today, we're going to talk about shame, stigma, and psychosocial distress, how they impact patient engagement, treatment adherence, quality of life, especially for our female cancer patients. We're going to talk about recognizing cultural, emotional, behavioral barriers that may interfere with their ability to help seek, engage in supportive care, or even just keep them from feeling empowered. Apply core principles from motivational interviewing to strengthen empathy, the therapeutic alliance we'll talk a lot about, and how that might be used in behavior change in oncology settings. We talk a lot about trauma informed, that's one of the big terms nowadays, and how this is actually using trauma informed patient centered strategies that promote emotional wellness, autonomy, compassionate cancer care. And we'll explore some approaches that all healthcare providers can use to reduce stigma, create safer and more supportive clinical environments for women affected by cancer. So intro, the hidden barriers of shame and stigma, I'm sure you see them in your interactions with patients. They can manifest in different ways. So sometimes that's the body changes that our patients go through, like losing all of their hair, weight gain, weight loss, scars, ostomy bag, even the cause for a diagnosis. If we're thinking about HPV, for example, there can be a lot of shame or stigma around that beginning into cancer care. We think about stigma around mental health in our culture. Um, for example, I had spoken to someone recently about, oh, have you ever considered counseling? And they're like, well, I'm not crazy, you know? So there's still this stigma about who seeks and accepts mental health care. What does it mean if you get a mental health diagnosis? What does it mean if your doctor wants you to take a psychotropic medication for depression, for example? There's a lot of stigma around that still in our society. There's cultural silence around sexuality and fertility for women. Being able to talk to your doctor or even your therapist about these things that impact you can be very difficult to overcome when there's shame and stigma involved. We think about fear of being a burden, especially for hyper independent women who are the sole providers for their household, maybe single. Um, Asking for help when they're not used to that can be really difficult. And guilt for not staying positive. We have that toxic positivity everywhere, or good vibes only that we see a lot, and makes it really hard for people to even open up about the difficult parts of cancer. Next slide, please. So, continuing with this, many women are not just fighting cancer, they're fighting shame and how cancer has changed them. For example, in many matriarchal households, women remain primary caregivers. We think about the sandwich generation for women too. Perhaps they're taking care of their parents and their children or grandchildren. And then when the caregiver gets sick, who's going to care for all these people? Who's going to provide for them if they're the only one working? We see that more and more that women are holding down the fort, and because of that, it becomes even more difficult for them to step away and get the care that they need. Next slide. So in our patients, we often see shame show up as something is wrong with me, and stigma might look like others will judge me. And anxiety and mental health symptoms can exacerbate this by causing some to avoid follow-ups, not ask questions in their doctor's visits. We also know that doctors may have 12 or 10 or 9 minutes with their patient. So being able to have the time to not feel rushed and ask questions when, especially when you're dealing with shame and stigma, can be really difficult. Withdrawing from support and can also cause delayed decisions in receiving care. So we're going to switch gears for a second. I know you're asking, like, why is this slide here all of a sudden? We are in the desert Southwest here in Albuquerque, New Mexico. Machismo is a term that is used pretty frequently, but I wanted to see if anyone has any ideas of what machismo is, the definition, or how it shows up in your clients. It's definitely not what's in the middle there, although it's funny, the irresistible urge to flex biceps that are quite frankly underwhelming. If anyone has any idea or ideas that they wanted to share about machismo and how that shows up in their patients or impacts their patients, please drop it in the comments or raise your hand. We will tie this together. Um, but first, we wanted to define machismo or get ideas from you what you think it is. Any thoughts or ideas out there?
Hi, my name is Yaritza. I'm an outreach coordinator with Crossroads for Hope. I'm Hispanic, so I understand what it means. I haven't seen it in the clinical sense much, but if I were to assume, it's probably um, a male that uh, may be arrogant in the manner where, like, if somebody's offering support, um, they find that that's not something that men would tend to look for, or or something that I think a lot of people can really is from what they've heard in society is men don't cry,
Mhm.
and that lets they absorb everything and don't let go, and that can cause further mental health issues, or not getting the help that you need.
Definitely. Thank you, Yadisa, for sharing that. Men don't cry is an excellent tagline for machismo. Um, I think Lisa also put in the chat, is it pride, unwilling to go against their ego? Maritza put a strong sense of pride. Yes, I think all of those intertwine when we think about machismo. And so in the next slide, we'll kind of tie it more together. So, once again, pulling this out into the desert Southwest where we are, we see this pop up in machismo culture as it's actually a Spanish term that can be defined as an exaggerated sense of superiority, manliness that defines gender roles within the male community. Men are expected to display their masculinity outwardly, proudly, which often can lead to harmful displays of power. Oftentimes, this culture is reinforced through one's childhood. So, even before you're born, these things are happening in the family. And why does this matter, especially for our Latinx female cancer survivors? Well, another term that is used often is like toxic masculinity, right? Is these really rigid gender roles that may define how a woman is seen in their community and their family, can place responsibilities of caregiving above their own health. Excuse me, above their own health, delaying cancer screening and treatment. I even think of just like feasibility. If you're taking care of your mom with dementia and your grandkids and you're working, and then your least priority has been your health, how are you going to step away from that entire situation if you have no help, So that also continues to add to it. Expectations to remain strong and resilient within the machismo culture can make it difficult to express fear, ask for help, just like Yaritza said, um, seek mental health support, not just for men. We know this impacts the whole culture. during cancer treatment and during actually the entire life cycle, right? It's not just cancer when this happens. And then cultural beliefs about femininity and sexuality may increase shame after body changes such as hair loss, mastectomy, hysterectomy, treatment-related sexual side effects, making it difficult not only to talk to your doctor about that, but how do you talk to your partner about this? How do you talk to your husband of 30 years? How do you talk to your whatever partner or friend, or if you're dating, you're a young adult cancer survivor? If we can't talk to our doctors about this, how are we going to be able to talk to someone we're dating about this? So, the larger culture of the toxic masculinity can make it really difficult for female cancer survivors to just even seek care and talk about what's going on within them and their body. Next slide, please. So, what is the answer, you ask? According to Dr. Brene Brown, fellow social worker and researcher, she says the first step is empathy. And empathy is important because shame thrives in silence, and empathy is actually the antidote to this. We're going to watch a quick video on empathy versus sympathy to remind us of kind of staying out of the trap of falling into the sympathy bucket.
So, what is empathy and why is it very different than sympathy? Empathy fuels connection, sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy: perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth, staying out of judgment, not easy when you enjoy it as much as most of us do, recognizing emotion in other people, and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, uh-huh. No. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had a, yeah. And we do it all the time because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Yes, thank you for that. I love the animations too on that. Let's go to next slide. So I'm going to turn it over to my colleague Myra, who's going to start tying all the pieces for MI.
Hi, everyone. Well, I was about to say good morning, but I just remembered it's just morning for Monique and I. So, all right. So we are now going to dive deep into what is motivational interviewing. So, motivational interviewing is a collaborative, person-centered counseling style designed to strengthen a patient's motivation and commitment to change. So, if you're asking yourself, why does it matter? Patients face complex issues as well as complex emotional situations, right? Given the nature of what they're currently going through. So it's a lifestyle and treatment related challenges. So MI helps reduce resistance, fosters hope, and supports adherence, right? The most important part is for patients to feel like they're being heard. And not only that, but also that we're meeting them where they're at. Next slide. All right. And the one thing that MI is not, it is not magic. So the expectation should not be that when you're meeting with the patient for the first time, you're going to get their full on commitment of, something that they're feeling ambivalent about, that, I am now determined that this is the change I need to make. As Dr. Miller, the founder of MI, would always state, it's about planting a seed, right? And it's important for us to meet patients where they're at. And so the expectation should never be, right, as you are walking out of my office or as I'm leaving the room, that you are fully committed to this change. Again, it's about meeting patients where they're at. Next slide. All right. So if you're asking yourself, how does MI apply in cancer care? So for providers, it is encouraging treatment adherence, right? Some examples of this could be medications, right? Chemotherapy, radiation schedules. So there's a lot of things going on, especially with the patient. And it's important for us to account, right, that they are going through a lot of lifestyle changes as well as potentially just in general having to deal with, the thought of here I am, right, with cancer. And so it's important for us to really seek, what potentially might be their concerns and being able to have those honest conversations. Now, it's also about addressing lifestyle changes, right? Again, some difficult conversations could be talking about nutrition. How does that change their maybe things that they're used to eating? Exercise. I think one important one that always comes up is smoking cessation, right? Things that patients have been so used to doing through the course of their time, and now this is a drastic change for them to make. And so it's important for us to have those conversations with patients. Also, exploring fears about side effects, right? It's important for us to definitely provide that non-judgmental and that this is a safe space. It's a very important thing, especially if a patient feels heard, if they feel like there's no sense of judgment, and no matter how they feel ridiculous the question might be, again, going back to what Monique was saying, based on some of the things that they believed to be some shameful things or potentially some stigma. These are moments for us to be able to have those difficult conversations with individuals. And so, again, providing that non judgmental free, we don't know what the patient's background has been or what they experienced before, right, receiving this diagnosis. And so, again, it's important for them to feel heard. Now, for social workers and counselors, right, supporting emotional coping and adjustment, this is definitely an adjustment, a lot of changes happening. And so it's important for our role to be the supportive individuals, in their lives. And so engaging patients in discussions about resources and support groups, facilitating conversations with family around care preferences. So a lot of right cultural stuff that we know, right? It's important for us to have those conversations about potentially, what are some of the individuals' culture that might be preventing them, right, to seek their cancer care. So these are some difficult conversations, but again, it's about meeting the patient where they're at and for them not to feel judged. Next slide. All right. So some of the core principles of MI, also known as the MI spirit, if you have any books on MI, some of the four key principles of MI are definitely some partnership, acceptance, compassion, and evocation. The overlap of all of this creates, as Monique was talking earlier, a high level of impact, of empathy, right? So we definitely want to use reflective listening to understand the patient's perspective. Again, no matter what they have just said, it's important for us to really come from in a lens of empathy. And it's important for us to see the gap between the current behavior and potential future goals. This is extremely important to have these difficult conversations with some patients. And it's important for us to roll with resistance. I know this one is a very tough one, right? Because a lot of times we want to avoid any sense of confrontation, but at some point, this is a lot of, right, some of the ambivalence, the patient talking a little bit about their ambivalence might, why this might be so difficult for them to further go about this change. But I'll discuss some techniques that we'll use in a little bit whenever it comes about rolling with resistance. And it's important for us to reinforce the patient's belief in their ability to make some of these changes, really valuing their strengths, affirming. These are a lot of techniques that can definitely be used, especially when we're having those conversations with patients. Next slide. So the number one and the foundation, and I'll talk a little bit about the 4 stages in a little bit, but the therapeutic alliance, right? Or just that patient to provider alliance, right? Where behavior change can occur, but it's important for the patient to feel understood, respected, and for them to know that this is a safe space. The more likely they feel like this is a safe space, the more they're going to talk about some of their concerns. And so it's important for us to really have those difficult, and again, just meeting patients where they're at. And so motivational interviewing, it's very meaningful due to the fact that we address a lot of the behavioral change. And it is something that it's a collaborative process. Next slide. Okay, so we talked a lot about ambivalence. And so ambivalence is, right, a little bit, if we see it, a little bit of tug of war, right? Reasons to wanting to stay the same and reasons for change. And so a little bit of the patient potentially going back and forth. Reasons of wanting to stay the same can definitely drive from an area of, I've been so used to doing this, and now all of a sudden I have to make this drastic change. And although I know these are changes that I need to make, right, to be able to live a healthy lifestyle, these are a little bit, right, hard for us to sometimes balance. So being able to reflect both sides and being able to lean on more of those reasons for change can definitely support a patient to feel more connected to that area for them to seek their own motivation. And so MI definitely focuses a lot on being able to kind of, right, be able to have those difficult conversations. And so there is 3 different areas of this, and we'll talk again more strategies on this. And so being able to focus, so being able to target our ambivalence. It's important, right, if we're having these conversations with patients, that we definitely create a level of focus. It's a relational aspect of this, so we want to avoid confrontation. It is very critical for the patient to feel heard. There is a technical piece of this as well, where we can definitely drive more of what we know this to be change talk versus sustained talk. So being able to get that commitment for change. And so I'll talk a little bit more about those techniques in the next few slides. Next slide. And so we talked about a little bit about the changes, right? About the 4 different stages that are definitely helpful to be able to move the patient, right, into this planning phase. And so engaging is one, right? Being able for patients to feel understood, listened to. This is a safe space. And so that is definitely the foundation. And so it's important for us to be able to roll with resistance, especially when we're in this stage, because, if the patient does not have, there's not that alliance yet, right? Patient to provider or patient to, you know, um, social worker, this is definitely an area that needs to be strong in order for us to be able to move to the different phase. And then the next phase would definitely be able to focus, right? Providing like it's a collaborative partnership where the patient also becomes part of, having these difficult conversations. Maybe this is where a lot of questions will come up, right? And maybe potentially, their fears. And so again, it's being able to build that collaboration. And evoking, there is some evoking strategies that I'll talk a little bit about, where we can definitely create more of that evoking. Like, let's talk about all your reasons of wanting to change, or your reasons of why wanting to do this behavior. Changing your behaviors would help positively impact, right, your cancer care. And the last phase is planning. It's definitely, it should always be a collaborative approach, right? Where we're having these conversations with patients, and patients are part of that conversation as well. Next slide. Okay, and so for core communication skills, especially for patient-centered conversations, right? We want to always engage patients with open-ended questions. So these are questions that require more than a yes or no. Yes or no questions are always known to be closed-ended questions. And it's important for us to provide patients with affirmations. So acknowledging their strengths, right? If there's a little bit of progress that was made, maybe potentially from our last visit, it's important for us to recognize that. And then there's a reflective listening piece, which is always shows understanding that they're being listened to, that there's validation. And then, I think this is a very important aspect also, right, on getting clarity from a provider lens. If this is what I think I heard, like, let me reflect that back and be able to see, did I get that correctly? And writers, it is okay. It's always, if even if the patient comes back and corrects you, this is a good thing. This is also lets them know you care enough to know, right? To get their understanding. And so summarizing is always being able, we always want to end up with a summary. Now, summaries don't have to be 5 minute long. It could be very brief and short. And the important part about summaries is always about highlighting the important things about the conversation. And so, again, you want to see this as a bouquet of flowers. You don't want to get too many flowers in the bouquet, because then all the beautiful details of the bouquet get lost. And so it's important for us to see that as that when we're providing summaries. What are the important aspects or the important keys that we just talked about that I want you to take with you? Next slide. Now, when thinking about strategies, right, one important aspect again, right, is being able to have those conversations. And I think this one's the one where we definitely have a conversation about sustained talk versus change talk, right? Sustained talk is every reason of why I may want to stay the same, why I may not want to further pursue this difference in lifestyle, right? Versus change talk is all the reasons of maybe why I want to seek this change. And so it's important for us to always lean more into the change talk, especially if the patient maybe with that conversation, they're giving us a sustained talk, and all of a sudden they're giving us a glimpse of that change talk and being able to lean in more into that change talk so they can further elaborate of what does this mean for them. Next slide. And so we'll talk a little bit more about reflective listening and empathy, just going back to what Monique was talking about earlier, right? Of us being able to have these conversations. And I'll talk about reflective listening strategies in a little bit.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me. And I can just feel it, like literally feel it in my head. And it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail out.
I'm not listening now.
Okay, fine. I will listen. Fine.
it's just sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just
Don't.
try to see things my way.
Oh,
Keep on talking till I
boy.
can go on.
Next slide. So as you all saw, right, the importance of reflective listening, meeting patients where they're at. And so it's important for us to, right, especially when dealing with cancer patients, being able to get validation before intervention, right? Again, we're setting up that tone, right, of setting, right, the foundation for all of that. And so next phase. All right. Now we're going to talk a little bit about reflections, and I'm going to make this a little, we're going to kind of go through it. So when we're looking at simple, there's two forms of providing reflections. There's simple reflections and there's complex reflections. So simple reflections are just simply stating, right, repeating what the patient has just said. Right? And then there's complex reflections. We have paraphrase, which infers meaning. Reflect affect emphasizes emotion, and then we have reflective values, right, highlights the importance. And then reflective ambivalence, it's really stating both sides, right? This is a very extremely important method that we can definitely use when it comes to some patients, right? If we've been listening throughout the conversation and maybe initially they talked about, you know, how their health is very important to them and they have to stay healthy for their grandbabies, right? And then now they're talking all of a sudden about how it's very difficult for them to completely stop smoking, right? Double-sided reflection is always, stating both sides always is very helpful because on one hand, you can definitely, and a good example is the one that I just mentioned. On one hand, you know, yes, it is very hard to make this change. But on the other hand, right, it's important for you to stay healthy for your grandbabies. And so again, and also it's a strategy, right? On what we're going to end on our second, on once we're stating both sides, it's always what the patient will normally will run off with. And so it's important for us to really hone in on that change talk. Next slide. Okay, Monique, this is where I'm going to call
Yeah.
for your help.
So we have a few case scenarios. We know that Echo likes for people to bring scenarios. So if you have any, think about them here. We are going to model the first scenario that's pretty common in our work here, and then really kind of demonstrate some use of the open-ended questions, affirmations, summarizing. And then if anyone wants to volunteer for scenario 2 or 3, or if we even have time, because we're running out of time, we would love for you all to practice some of your MI skills today, if you have a chance. So scenario 1, I'm going to be the patient. Myra's going to be my doctor. I'm supposed to get treatment today, but I've been called in because they're saying my cancer has progressed. There's no more treatment options for me, and I'm probably going to just be referred to hospice. So okay, Dr. Perez. So I wasn't prepared for this today. It sounds like you're just gonna throw me to the wolves and stop my treatment and send me to hospice, and I'm not ready for that.
Well, first of all, Monique, I want to appreciate you for, you know, being vocal about that and raising some of your concerns and potentially, you know, where you stand with all of this. I know it is very difficult. And I just really want to highlight, right, that you have been extremely strong throughout this whole process. And so I want to, I want to kind of have a conversation with you about, you know, where do you stand currently? What would be helpful for you at this moment?
I don't know. I just feel lost. I mean, I was coming in for my treatment today, and now you're telling me there's nothing that can be done and it's over. There's like not even time to process this. I feel lost. I feel scared. I'm upset. Not ready for hospice. I'm scared of the word hospice, I don't even know what to do.
Yes, yes. And all of this, I know there has been a lot of changes, right? There's a lot of things, especially when it comes to everything that you've gone through, but again, I want to appreciate, you raising your concerns. Now, I know we're running out of time, and so would it be helpful for you, Monique, if maybe we set some time for us to have a conversation about maybe what you think hospice is, and maybe potentially how hospice can be helpful for you at this time?
Yeah, I mean, I think I need to digest it and I don't know, talk to somebody else about it too, like another doctor. I don't know.
Yes. And, Onik, I want to make sure that this is as comfortable as it could be for you. So I'm more than happy to facilitate that for you to have a conversation with another doctor. I think it's extremely important for you to feel heard, right? And also feel free to write down any questions you may have. I know it's a very hard time, and so I want to make sure that I'm here to be supportive as possible.
Thank you. Yes,
You're welcome.
I think that's a good wrap up there. It's really hard to get all of the different things, of MI into one conversation, but just reminder to slow down, slow down when we're looking at the intervention of passing to hospice and then realizing like, oh, they're not ready for this, let's talk about it. So yes, thank you for demonstrating that. Do we have any volunteers from the audience that want to practice scenario number two or number three or even their own scenario? They could be the patient and we could be the provider, or you could be the provider. So I'm just inviting anyone to raise their hand or put a comment in the chat if you wanted. This would be a great time to practice some MI skills. And if not, that's okay because we're running out of time anyways. But yeah, I think about the smoking cessation right prior to surgery is often one that is so difficult to have. And so slowing down, really listening, asking the open-ended questions like Myra said, what do you think you need to make this happen? Um, what are your motivators? And if they're not even motivated to do it, then we're not going to push them either. We have to evaluate where they're at. And if they're not ready, then we're just going to say, that you can't get the surgery if you can't stop smoking, but I'm here to support you wherever you're at, and really diving into that therapeutic relationship of trust and non-judgment. So yeah, I think we'll go to the next slide because we are running out of time. Hopefully you got to see a little bit of an example, and I'll pass it back to you, Myra.
Yes. Well, as Monique was definitely, it's about planting the seed. We know you all are limited with time, right? And so it's important for them to feel heard. And again, right, letting them know like, hey, it's okay. Why don't you write your concerns down? Why don't we have this conversation and maybe we start off with your list next time so that they feel like they're part of that process. So again, the benefits of MI, it really provides a positive outcomes, right? Whenever it comes to any lifestyle changes. It improved adherence to treatment plans, right? Them being part of the process, reduce anxiety and depression in patients. This is a very hard time in their life. And so it's important for them to feel heard, maybe questions answered that could definitely help with their anxiety and better caregiving coping, and it reduces burnout. It's a great way for it to lean more on the patient and their needs versus I'm the doctor or I'm the counselor or social worker, and it's important for me to get their perspective of where are they at, right? And it brings a stronger provider patient relationship as well. And so with all of that being said, yes, I want to thank you all for taking the time to attend our presentation. And Sarah, I'll refer it back to you.
Well, thank you both for doing this. This was amazing. And I know it's so early for you, so like we double appreciate you coming out here and talking about this. If anybody has any questions, please feel free to unmute or put it in the chat. I can't see the chat exactly, but I'm sure if you have a question, someone will see it. But feel free to unmute, ask anything. I know I actually have a question, so I can go if you guys don't mind.
Yeah.
I had a question on the reflective listening part. So does reflective listening, does that also include like body language, like mirroring that? And also when we were going over like the complex and the simple types of reflection, what's more important, or is there a good combination of both?
Yes, that's a very good question, Sarah. Actually, something that, research has said, especially when a patient might be using a lot of sustained talk of reasons to not wanting to change, simple reflections are very good. You're highlighting, we're rolling with the ambivalence, we're rolling with resistance, right? And so it's important for us to, yes, I'm hearing you, right? But I'm not going to add any meaning to what you're just saying, right? Or double-sided reflections. I'm stating of all the reasons of why I may not want to seek this change. This change is very hard. Every time I go out with my friends, they're smoking. So why would I want to make, this change? And so it's important for us if we're listening throughout the conversation and they provide us a little glimpse of their change talk, that this is, they want to live a long life. They see themselves traveling, right? Like these are important things for us to really highlight the meaning of, yes, I'm listening to you. And at the same time, right, these are some of your goals. Like, where are you with that? And so, yes, but that's a very good question, Sarah.
Yeah, if I could add, I wanted
Yes,
to add in that video we watched with the nail in the head, he actually did a complex reflection when he finally like realized she's not going to listen to me if I want to intervene. He's like, that sounds really hard. And actually, it seems pretty simple, but that is a complex reflection because that's not exactly what she said, but he's rephrasing and putting back to her the meaning of it, right? And so sometimes we don't have to pretend that we know what they're going through, especially if we have never been through cancer before. I think in the empathy video, she said, Brene Brown said, "Whew, that sounds horrible. I don't even know what to say right now, but I'm just so glad you told me." So that is another reflection, but I think it's like when people see the mirror and they see themselves, they hear themselves too, they process, right? And so we don't want it to be just a mirror of like, oh, you just continue to say everything I'm telling you that doesn't help me, because people can get upset with that. But we want it to be genuine and we want it to be like the meaning under that. It sounds like you have a lot on your plate, is what I say to a lot of people. Your plate is full and then some. Things are falling off your plate. You are really stressed out right now. I can hear that. You're really upset right now, and there's no judgment with that. It's just saying I can see that, I can feel that, and that must be tough with everything you're going through. So there is not like one or the other. It's just kind of going with the vibe of what you're seeing and what you're reflecting. And then yeah, just staying out of judgment. And then I think it's really important to not just stay there. Like eventually you have to go from the mirror to doing something, but you kind of gauge, Sarah, where they're at. And then when I was taught in my master's program, do not overestimate the ability of just empathetic listening, which is eye contact for a lot of people, nodding, being in that emotion with them, like, whew, that sounds all like a lot, right? You may not even know what to say, but the fact that we can't do this on the phone and we can't do this virtually as well, but like, I'm here, I'm listening. For some doctors, sit down, stop standing up, even though you have 4 minutes to go. Like, sit down, look at your patient, take a breather for yourself, and then really be present with them, even if you only have 4 minutes. That will help that therapeutic relationship to really connect, I think. And it's a reminder to all of us because I'm in a rush all the time too, you know.
Thank you so much, Monique. There is a comment in the chat. So Monique was an unusually insightful patient in this scenario, very in touch with her feelings and understood what hospice meant. What if a patient just starts crying and asking, "Why are you giving up on me?"
I think that is a really difficult moment, Angie. Thanks for bringing that up. We see that a lot. Um, that feeling of like, I would reflect that a little bit because as a doctor or provider, I'd be like, oh shoot, that's not what I meant, right? That'd be a cue to me like, oh man, they feel like I'm giving up on them. So cue to self, we're not aligning where we're supposed to be, and then reflect that. You really feel like we're kind of abandoning you. You're abandoned right now. You're being given up on. That's how you feel right now. I would reflect that to make sure that we're on the same page, right? And that they hear that, and then really kind of be like that. you've been through so much to feel like we're dropping the ball. I can't even imagine how that feels. So some really deep reflections and just sitting in the uncomfortability of that. And then apologizing as a provider, like, I'm so sorry that that's what you feel like. I didn't mean that way. And then maybe an open-ended question, right? What do you need at this moment to help moving forward with the information you received today? What do you think would be helpful right now? Um, is there anything we could provide for you? And sometimes it's just sitting in the uncomfortability of that without the quick intervention. But I know doctors, it's much easier for me to say that as a therapist than a doctor who's like, I got to move forward, right? And Myra did say, why don't we schedule another appointment? I think that's the other thing. We often have the doctors may have, or the nurses, you have 4 minutes with a patient, you got to get to their next on the list. But then you could say, you know what? Why don't I call you next week? Do you want to come back next week? Let's talk about this again. We don't have to decide today. These are really difficult decisions. I'm empowering you to make your best decision for your body and your life. And I just want to be the provide, I want to walk alongside you on that and help you if I can, connect you to anyone, even if it's a provider outside of me. I always tell people, you want a second opinion, you want a third opinion. Insurance will often cover that. I think if that's what you need to feel sure in your decision, I absolutely support that. It's not about me. It's about your ability to trust that this is the best decision for you? So that's another time.
Yeah. And I think just to kind of add on to that as well, I think when, um, highlighting where is the miscommunication, right? Hospice, a lot of times, right, especially depending on their culture, hospice could be seen as a very horrible thing, but in reality, there's a lot of resources there. So really ending up with that. And, like this is a resource for you. Again, this is not something that you have to do. It's just they provide all these X, Y, and Z. And so again, like let's like, like we were talking about it earlier, planting that seed of like, I care and it's okay. Take the time. I know this is something very hard and you've been extremely strong throughout this whole process. And so, I appreciate you for sharing that and feeling comfortable enough to let me know, how you're feeling at this moment. And so again, right, being able to like hospice is one alternative, but there's other alternatives you can also further continue to pursue. And so being right as providers being able to have a little bit more of that conversation of like what are their options, and for them to feel part of the process and that planning phase.
Thank you so much for that. And thank you for asking questions. And as always, if you have any questions later on throughout the day, if you come up with something, if you're still thinking about this, because I feel like this is something I'm going to be thinking about for a while, but also just throughout my day, I'm going to be reflecting on this. We have our Mighty Network, so you can put the questions in there, and Myra and Monique both have access to that, so they can answer the questions. You can email me, and then I can forward the questions to them. I'm gonna launch the post test now. And then we have the answers on the next slide. So if you could just take a minute. I know we're a little over time, but this was such an amazing session and very impactful. Just let a few more people do it, and then we can. No, actually, we're right on time. My laptop is fast. Monique or Myra, do one of you want to go over the answers? I have them on the next slide.
Sure.
All right. I'm ending the poll, sharing the results, and then here are them.
Yeah, so feeling understood and respected by a healthcare provider can influence a patient's willingness to engage in care. That's the therapeutic alliance, right? Yes, absolutely true. A patient can understand the medical benefits of our recommended behavior and still feel ambivalent. We all feel ambivalent about big changes, you know? So, yes, true. MI is primarily focused on persuading patients to make the changes their healthcare provider believes are best. False. This is false because it's not about only what the provider wants, it's about what the patient wants, right? And so we make that decision together. Often I think it's a misnomer of MI, like, we're going to get the patient to quit smoking because we know MI. False. We're going to see if the patient is ready to quit smoking and engage in the therapeutic relations to see if we can help them with that. If that is not their goal, it's not our goal. Number four, it's not just behavioral health providers, right? It can be anyone that uses MI because anybody can have that therapeutic trusting relationship with the patient. And the last one, magical thinking, by encouraging focus on behavior change. Well, kind of, but it's not. We don't use magic, right? And we don't. MI is not magic. It's really just all of the things we talked about, helping people meeting there where they're at, and then evaluating, is this important to you? What are your goals? And then we just remind them, really, you, on one hand, you want to quit smoking, on the other, you've been smoking for 40 years and it's really hard, right? Without judgment, totally without judgment. And we live in a judgment society, so it's a permission and reminder for us to be like really in with the patient. Doesn't mean we're agreeing with them if they have bad habits or whatever, but we're really just, that's where they're at. There's no judgment. And how do we get them to want to move towards their goal and support them in that? So, yeah.
And then I have a little shout out for your guys's Echo. And I'm gonna put this on the Mighty Networks too, because I know it's like a two-part flyer.
Yes, we do semi quarterly version. So our next one's not going to be this week. It's going to be next week, August. And actually that date is wrong. I need to send you a new flyer, August 6th. It'll be next Thursday. At 12 noon Mountain Standard Time. We're talking about adult self-care from a breast cancer survivor. So please join us, register. If you can't join us, you'll get the recordings online. And from one echo to another, we hope that you just get more tools to be able to do your job better and feel more empowered in the work you do. Thank you for all you do.
And then just some last minute slides to wrap up with. In New Jersey, we have NJ Seed, and they do cancer screenings for breast, cervical, colorectal, and prostate. And I know the phone number and the link will all be in the chat. And thank you so much for attending today's session. I forgot to put the QR code, but I know that it will be in the chat. So please let us know how we did. Let us know what you thought about today's session. And there's also a part where you can put topics that you want to see. And we do really look at that feedback. And then again, everything will be uploaded to our Mighty Networks. I'll have their contact information as well. So if you want to reach out, you can. And then join us August 23rd, or the fourth Tuesday, for a session on GLP-1s in oncology. We're getting a doctor from Rutgers Cancer Institute to come and do the presentation.
August 25th, it looks like.
Thank you. All right, and thank you so much again to our presenters. We really appreciate you taking the time out of your schedule to do this.
Thank you.
Thank you. Have a great day, everyone.